Welcome back to Diversion Insights, everybody. Today, my guest is Carol Davis. Carol has spent many years as a CRNA on the East Coast. She is now retired and fully enjoying her free time, I'm sure. Welcome, Carol.
Thank you for having me.
Absolutely. I asked Carol to join me today because she has at least 3 experiences with diversion from her time in the OR. And boy, are they experiences. Before we get to that, I want to know first, Carol, did you have any awareness of diversion or substance use disorder within the healthcare population prior to your work as a CRNA? You were a nurse in ICU first. Did anybody educate you? Did you have a colleague that went through anything? Was it even on your radar when you began your work in the OR?
No, I had no experience at all. I had been in the ICUs at 3 different hospitals for 8 years before I went to CRNA school. And it was back in the late 70s, early 80s. And back then we had a book that with one person had a key, you got the key from her, you went into the narcotic cupboard, opened, counted how many were there to make sure it was the right amount, wrote down the patient's name on the paper and put the final amount was and use the drug. And if you didn't use the whole thing, then somebody would co-sign with you to use it. I just thought of something. I did know somebody.
Oh,
my very first job, I was out of school. I was working on an orthopedic floor night shift. And I had not passed my RN boards yet. So I wasn't allowed to take up the drugs. I used to have to go and tell the nurse who needed the pain medicine, etc. So one of the nurses on night shift said to me, just here's the keys. I trust you. Just go do it and scribble my name. And so I said, fine. And she later on, probably about a year later, she died of a drug overdose.
Oh,
yes.
Okay. So that was, were you still working with her then, or that was after?
I had moved on, and it was, she was found in a field in the middle of winter, and she had been reported missing, and she had died of a drug overdose.
Wow.
I just, again, it was something that she never thought of because it was the same way as it was in the ICUs later on. You had the paper, you signed it, you put the patient's name on, you charted in the chart that they had that much for medicine, and nobody ever looked back.
Right. Yeah. And connecting the dots, you probably didn't connect them, but it's just having this conversation that you're like, wait a minute.
Yeah.
Interesting.
About Megan. Oh my goodness.
Okay. Yeah. So just do whatever, sign my name. I wonder, if she was diverting from work or if she was using something from the street or what.
I think it was
both. Okay. Yeah. But bottom line is when you went into the OR at this point, you hadn't really connected those dots. Yeah. So it wasn't on your radar.
It wasn't on my radar at all.
Okay.
I know as a student CRNA, we were always told that they're in classes that, anesthesia providers were the highest group for diversion.
Okay.
But they never really told us anything about how to prevent it.
Sure.
Or anything like that. So we just knew of our minds. And I couldn't even imagine doing something like that.
Yeah. Okay. So let's jump to your first story. It is it actually stresses me out just thinking about it. So tell our listeners, what was your first experience with diversion in the OR?
Well, I was a year into my CRNA program, and I was in the open heart rotation. So we used to have to get there early. I'd get there like 5:30 in the morning to have the patient ready for 7:30. We'd have to have our room set up. We'd have to have all the IV lines and special monitors inserted in the patient. You were usually alone in the recovery room, except if there were patients from the night before still recovering until probably about 6 a.m. when the day shift started coming in, and the day shift had an anesthesia resident on rotation. They would do 30 days in the recovery room so they would learn how to take care of patients post-op. So I would sometimes fall behind if it was difficult to get a line in somebody. This particular anesthesia resident was very friendly, and he said to me one day, "I'm not busy. Do you need some help?" And so back in those days, cardiac anesthesia basically meant that you put your patient to sleep without the thoughts of waking them up until the next day. So you routinely got about 5 to 6 20 cc vials of fentanyl handed to you from a pharmacist, and you went in the room and drew it all up and gave it during the case. So if I was behind, I gave him my fentanyl and said, "Could you do me a favor and just go draw this up for me?" And he said, "Sure, not a problem." So I would go about my day, and I started noticing rotation was a month long. And I noticed several times that my patients would start to get a little light during the poop run. And I think, okay, what's going on here? Did the patient not tell me they drink a lot, or maybe they use, but for some reason they're taking a lot more than normal. But I didn't really give it much other thought. So when my rotation ended, I was assigned to the GYN rotation, and I was in a room doing a case, and we always get breaks either from the anesthesiologist with us, another student, or a resident, or somebody when it was time for lunch. So you just took whoever came. So he came in the room one day and said he was free and he was there to give me lunch. And I said, sure. So I came back from lunch and noticed that the patient was moving a little, didn't seem to be deeply asleep enough. And this was in the days before there were like BIS monitors, or you basically had a blood pressure cuff and a pulse oximeter if you were lucky, and a heart rate monitor, and that was it. So one of the things working in this operating room, because it was a large teaching facility, was they had a pharmacist assigned to the OR. And she was in the recovery room. She had a little office in there that she would hand you your drugs out the window. And you had to hand in all your syringes at the end of the day if there was anything left over, and they would be randomly tested. Well, mine got randomly tested and came back sailing. So I was called in and said, "Are you using?" And I was like, "No." I went through a drug screening. It came back negative. So it happened to a couple other people in the OR too. So everybody came back negative. So they called us all in and said, let's try to think of common denominators here that you had. And the common denominator turned out to be the anesthesia resident. And so they called him in, had him tested. He failed. They sent him to Georgia for rehab. He came back later on. They accepted him back into the program for a second try, which I thought he should go into something like radiology or podiatry or something that didn't involve the drugs. But he came back into anesthesia, and on a random sample a few months later failed out.
Wow. Okay. So here you are, a brand new student, CRNA. I cannot imagine what you felt like in the OR the very first time that your patient started waking up.
You're trying to figure out what you did wrong. You have your there was always a CRNA available for the student or the doc who's doing the case with you, the anesthesiologist. And you sit there and you try to troubleshoot and think, what's going on here? Why is this happening? But I don't think it was on anyone's radar that somebody was diverting drugs.
Yeah. Yeah. No, you just assumed you did either something wrong or you didn't get a full history on that patient, right?
Right.
And how stressful that must have been for you. You're still learning and trying to do everything, and a heart rotation, for goodness sakes. I'm sure that made it even worse. And for somebody to put you in that position, I mean, that just shows us how much the disease 100% just takes over somebody's life, because he was willing to throw you completely under the bus. And I mean, you weren't even an experienced person that, would have enough experience to deal with it. Right. So it just kind of shows us that. And kudos for the pharmacist and whoever else was involved in kind of connecting those dots and realizing, wait a minute, there's something else here and we need to get to the bottom of it. And you're right. Anesthesia providers have such a higher rate of substance use disorder. I think it's just, access, and they're very comfortable with it, right? I mean, you feel that you're kind of invincible and you know how far to push it and you will always be safe. And then it just gets out of control. And so very sad that he couldn't be completely and stay in recovery. And it is dangerous. There's different viewpoints on whether they should be allowed to come back to work. And in this case, there was an issue. So thankfully they had a monitoring program set up though, and they were able to discover it, hopefully before, too long. He had seen too many patients. All right. Your second experience is also a little harrowing. And we'll find out in a minute why it really touched you personally. So tell us about that.
Well, my second experience, I was working at a different facility. And
how long after was this from the first event when you were a student?
Probably close to 20 years.
Oh, long time. Okay. Long time. All right. Okay.
And I was working in a facility that, a large hospital, again, they didn't have anesthesia residents, but they had surgery residents, et cetera. I was actually the chief CRNA there then.
Oh,
and I was the second CRNA hired. Previous, it had been all docs. So one of my best friends came to work with me, and we worked together for about 5 or 6, it's probably about 5 or 6 years. I trusted her completely. She trusted me. Our families did things together. I gave her anesthesia. She gave anesthesia to me and my family. We spent holidays together. Our children were close to each other. And she started having a problem with alcohol, which her daughter had let us know. And so her daughter basically talked her into AA, going to get help. She got clean, and she kept working the whole time. Work did not know at all about the problem with the alcohol. She was never drunk at work. She used to leave work and she had in her coat pockets those little airplane bottles.
Oh, wow.
And so on her way home, she would drink. And then she would drink when she got home. So I was out of work on vacation because my daughter was graduating high school. And I had to take her for orientation for college. And my mother-in-law was having surgery for breast cancer. And she was having surgery there, so I automatically asked her to do the anesthesia. And, she did the case. And after the case, I saw her in the recovery room. And I was looking at the anesthesia record thinking that it was really strange that my mother-in-law, who doesn't drink at all, and, it's very fit, doesn't take anything except high blood pressure medicine, had required as much narcotic as she did. But I thought, okay, well, maybe the stress of having breast cancer did something for her. So, my mother-in-law was awake and she was doing fine. And the chief of the department came in and said to my friend, I need to see you in the office. And so I said to her, okay, well, just call me later when you get home. And she goes, okay. So I went home and I didn't hear from her. My mother-in-law was at home with us. And I called work, and the couple of colleagues of mine there said that they had not seen her after she went to the office. So I called her at home, and her husband told me that she had been asked to give a urine sample for drug diversion, and had been unable to do it, and had refused to give a blood sample, so that they suspended her and that she was at home. So I got on the phone with her and I was like, why didn't you just give it? And she goes, I was just too stressed out. I couldn't go to the bathroom. And I said, why don't you just give a blood sample? And she's like, well, I called my husband. He says, if you didn't do anything wrong, don't do it, because they could always mix up the samples or something. And she goes, I says, okay, fine. So tomorrow morning, I'll come and pick you up, and we'll go to HR and we'll do the specimen, etc. And so we hung up. So the next morning she called me and said that she had gotten fired for not doing it, and that she was going to call the board of nursing and find out what steps were next. And so I was on my way to Ohio with my daughter, and so we talked in the car for several hours on the phone. And I was trying to think of all these things that she could do to prove that she had not used.
Yeah, you were supporting her.
And, I was trying to be very supportive. And then finally, by the end of the trip, she admitted, and I was even saying, go and offer to do a hair sample. Hair samples will tell you a better story than a urine or a blood sample. And she finally admitted to me that she had used. The hospital that we worked in didn't have, when I originally started there, they had a pharmacist who gave you drugs, and you just filled out the sheets with the patient's names and how much you used. And then they decided for cost cutting that they would just put in Pyxis machines in different parts of the OR. So you could just get your narcotics out at the beginning of the case, and you would either return them or waste them with another anesthesia colleague or one of the RNs in the OR. And everybody had a number or a password that you used as a replacement. So because we trusted each other, a lot of us gave each other our numbers or passwords. So because you have this 15-minute turnover time, and they're yelling at you to hurry up and get back in the room and do the cases, because time is money. And so you would just return it yourself and use somebody else's password. What had happened was they had suspected somebody was using, but they weren't sure who. So they started looking at names, and they noticed that she was using my name to return stuff when I wasn't working. So how could I have been her return person when I wasn't even there? And then, she would go on breaks for a longer period of time. So she ended up having to go to the board of nursing. And I knew that since she no longer had access to the fentanyl, that she would test negative because her appointment wasn't for 2 weeks. So we have a peer review person in our state organization that they're peer assistant, really, so that if you have problems with drugs, alcohol, mental health, etc., you can be put in touch with them to help you through it. So I knew him, and so I called him and said, I'm really concerned because this fell off the radar for how long. I know she's going to test negative because she hasn't been using, but I'm really concerned about her going to work again without going into some sort of rehab. So he said, I'll take care of it. And he made it so that the test was positive. And so
somehow,
so she had to go to rehab. I felt guilty, but I felt I had to do it to protect her and protect the patients.
Mm-hmm.
And went to rehab for like 3 weeks, came back, got another job at a surgery center, was doing well until she says like she forgot to return to the vial of fentanyl. I had left it in the lab coat in her locker. So when they went to do the count, that was off. And so they went and opened everyone's lockers and found the fentanyl in her lab coat pocket. And because the chief there knew of her history of diversion, they went and fired her. And they brought charges up for stealing narcotics. And she got arrested, a court date, and the judge told her that if she successfully completed rehab, that it would not be on her record. So she went back to rehab for about another month. And so they dropped the charges, and she just had to pay a fine. And she went back to working at small surgery centers. And I lost touch with her. My husband had a real hard problem that she did that with his mom. And so we just stopped communicating. I think that she's finally retired. My daughters and her daughter still keep in contact with one another, so I find out things somehow that way. But it was awful because, I felt terrible that I hadn't seen the signs. I felt terrible that I called and said she was using, and if she tested it, to get away with it. But, I had to do it.
Yeah. Well, you knew that she had a problem with alcohol. Did you see those changes in her behavior, or was she managing to kind of keep that quiet? If her daughter hadn't have told you,
would you have kind of quiet? I know she was under a lot of stress because she and her daughter were very close, and her daughter was going off to college. And her husband traveled in lots of work, so she was home alone a lot. And, I could see that her face had gotten puffy. And she was at a Christmas party and got really drunk and fell and broke her arm. And that's when it sort of came out about the problem with the alcohol.
Okay. Yeah. I mean, you did what I think many people do, is they attribute those changes to something else, right? She was going through issues at home with her daughter leaving and her husband traveling. And so it just didn't occur to you that there was any kind of substance use. It was just, and then she got drunk once. Okay. She got drunk.
Yeah.
Yeah. So to put the two I mean, it's hard. It's hard to see that. So at some point, she either added on her controlled substances or started to substitute the opioids for the alcohol. Yeah. And sharing passwords. Yeah, that was the day. Now they're bio ID typically, right? But back in the day, it's all passwords and you, I don't know. I've never worked in the OR, but you always hear this. We got to turn this over fast. We don't have time for this. I mean, that has been consistent for years that we hear this. And I don't know how often it's an excuse or it's just like, well, you know what? You got to take 30 extra seconds because you can't be doing this. But here again, that's what you said, right? We have to turn it over fast. We don't have time to wait for each other. This just worked out better. And we trusted each other. Yeah. Yeah. Okay. All right. So that was number 2. Now, this doesn't only affect anesthesia providers. We all know that. So you've now got another story that involves an OR nurse, right?
And she actually worked for the Department of Anesthesia. Because before the nurse anesthetists had come to the facility, there were only doctors. So they hired RNs to help them set up their rooms, get their narcotics for them, help turn over their rooms while they were in the recovery room, things like that. And looking back on it, it was like, it was a right setup,
Sure.
So she had been there for years. And about 6 months before this happened, she was trying to hurry coming into work from the parking lot. So she took a shortcut down a hill. And it had rained the night before, and she slipped and fell and broke her leg. So she was out of work for several months while her leg healed. And when she came back to work, didn't notice anything different about her at all. Still was running around like she usually did, would always help you out, things. Then one morning, somebody found her in one of the equipment rooms that in the OR when they went to get a piece of equipment. She was unconscious on the floor, and there was blood coming from, where she had fallen and hit in her head. So she got taken to the ER, and everybody had thought, oh my God, I wonder why she passed out. Did she pass out, or was the floor slippery and she fell, etc.? And then, because part of their protocol in the ER when someone comes in unconscious is to do a drug screen.
Nice. Okay.
Yeah.
All right. Yeah, this speaks to how important it is to have a standard workflow and protocol. And I always tell people, and this kind of is wrapped up in that same thing. The diversion specialist needs to have a relationship with the risk department because things happen that you're not aware of, but they need to be aware of diversion and the possibility or impairment and to look at that. It's the same kind of thing. It all gets wrapped up into that protocol. It's not normal, right, for someone to pass out or to be found down. And so, what is your protocol? So, and I wonder, if she was one of those that got exposed after her injury, and as happens so many times, that after that she was hooked, essentially.
Yeah.
That's sad. Yeah. And I want to go back to you feeling guilty about calling that person that was involved in the testing for your friend. Those are hard decisions to make, but you knew that there was a patient safety issue, but you also knew that there was a safety issue for her.
Exactly.
And that is the message that we really work to get out to the facilities, because people are leery of reporting or saying anything. What if I'm wrong? What if I'm wrong? It's like, but what if you're right? And they end up not surviving because their SUD has escalated so much, and that is the outcome, right? That is one of the real outcomes. So, I get you feeling guilty, but for what it's worth, I think you did the right thing, making a call and giving someone a heads up.
It was very, very hard. And that happened
Yeah.
16 years ago. Yeah.
Yeah.
16 years since
Yeah.
that happened. And I just told my daughters about it this past week.
Oh, because you better tell them before the podcast comes out.
Yeah. And I said,
Yeah.
I said it's, the entire time that I worked, you knew that you couldn't use anything, especially pot, because, pot sits in your system for 30 days. And there was an OR tech who got suspended because on a random drug screen, he tested positive for pot. But what he had done was 2 weeks before that, he was at the ocean on vacation and smoked some pot. But there was no way that, you could tell that. He ended up, many people went to bat for him, that he ended up getting his job back. But you start to think about now with all the states that are legalizing pot, like what's going to happen? You know, how do you separate that out?
Well, and it is. And at the same time, though, facilities ask that question all the time. How can we do testing and what do we do with marijuana because it's legal here? But at the same time, people can still be impaired on marijuana. And so really, I don't want you in my OR if that's what's going on, even if it is legal. So, should healthcare professionals be called to a higher standard? It might be legal, but that doesn't mean you should be doing it. So it, and it, in terms of with your friend, right? It's another example of how the substance use disorder takes over completely because she was using your code to get access to things or to waste things, under your name, so that she could take it for herself. So again, another example of it just gets out of control and they don't care what is happening. It doesn't mean they don't care for you. It just means their addiction is so strong that they will do anything. So hopefully she has gotten the help that she needs and is still in recovery and can understand why you did what you did. And, you tried to support her even for quite some time through that.
Yeah. I don't think she knows that I'm not a peer person. And
right. Yeah. Well, hopefully she's in a better place now. Yeah. She can look back and be thankful for that initiation to get her started in treatment. So, all right, listeners, if you didn't have concern prior to hearing these stories, I don't know what would make you concerned. We need to partner with our team in the OR. Carol, do you have any suggestions for listeners in how we can do better to mitigate the dangers of diversion in the OR?
I think there needs to be more of a collaboration between pharmacy and anesthesia, because right now, like the last few years that I worked, we were really big into doing ERAS protocols, which are advanced recovery after surgery. So you're using multimodal types of anesthesia instead of just giving everybody gas, narcotics, and waking them up. You're trying to block pain pathways before they occur. I used to do a lot of spine cases. I was the spine person at the place that I worked at. And the protocol for ERAS, there were 7 different infusions that we used. And we had to make all our own infusions. The pharmacy said they just didn't have the personnel to be able to do it. So you're making these infusions, you're setting up your room, seeing your patient. I would get there at 6:45 in the morning for an 8 o'clock start, even though I didn't get paid till starting at 7:30, just to be able to be ready. But then you'd have a second case that would need to go into the You're told, do not get ready for a case when you're in the middle of a case previous.
Yep.
But you have to, because it takes almost 30 minutes to get that set up all together. So you have your own Pyxis, and you're pulling out drugs and the other person's for the other person and trying to make up your drips while you're doing things before. And sometimes you don't pull out the drugs for the right patient. And so that happened to me a couple of times. I had to go in front of this committee at the hospital, and they were like, okay, we can see where the mistake was made. And my boss would be like, oh yeah, well, we're just going to have the anesthesiologist with you help you make the drips so you can get it done quicker. Well, police, that never happens. And they never set foot in the OR. So it's like there has to be some way that this we're doing these different approaches to anesthesia, that we have the backup to be able to help us safely do that.
Yeah. Yeah. That's
difficult to do in a 15 to 30 minute turnover time.
Yeah, that's a good point. And that really does that collaboration piece of it to understand, we talked about it before. We don't have time. It's a quick turnaround. It's like, yeah, okay, we'll take 30 seconds. But you've just brought up a point that would take more than 30 seconds to prepare things. I would like to think that more are going toward pharmacy making things, because that seems to be the trend. We really don't want people making things outside of the pharmacy, so I would hope that's happening, but it's a good point. So between, educating to what diversion is all about, and that it may not be you, but it could be somebody working with you, whether it's an anesthesia tech or a nurse or, a student or a resident, monitoring for things that are going on in there, making sure that staff know about available resources, where if they do suspect somebody or if they are struggling, and then developing those relationships so that people may feel comfortable reporting something, but also so that there can be real collaboration of, let's make this work for everybody. So it's a safe place for everybody. And, especially our patients. Yeah. No, that's all good points.
It has to definitely be a team effort to be able to do it, because it's just too easy to make a mistake otherwise when you're playing.
Yes. Okay. Well, thank you, Carol, sharing these stories. Maybe it's been a while since you've thought about them. Maybe with your friend, it's something that has been on your mind. Hopefully it helped a little bit to get it out there and to share it. And thank you for all of the years that you served in the OR so diligently. And I appreciate your time with us today.
Thank you for having me.
Absolutely.
Step like
Okay.